Our last speaker is Dr. Mary Jane Randlett. Dr. Randlett was born in New Brunswick and grew up in the beautiful city of Fredericton. She is a graduate of the University of New Brunswick and Queen's University. She obtained her medical degree from Dalhousie University in Halifax in 1983. She met and married her husband and began her practice, in Toronto and Oakville. They soon moved and made their home in Cornwall. Impassioned by an introductory lecture about palliative care in med school, she devoted herself completely to her patients and their families by incorporating home visits and palliative care into her practice. Dr. Randlett soon became an advocate for end-of-life care in hospice in our community. She worked tirelessly with a dedicated team to establish a home for palliative care. The community of Cornwall and the 5 eastern counties of Ontario are the beneficiaries of the work of that committee when Cornwall Hospice opened its doors in September 2009. Now retired from her regular family practice, she is focused exclusively on end-of-life care for patients and their homes in the hospice. Please welcome Dr. Mary Jane Randlett.
Thank you, Dale. Okay, so I looked at the agenda for today and realized you've had a very comprehensive day with lots and lots of information. And I'm here to speak on my favorite topic, which is palliative care. It's not going to be a long talk because it's pretty straightforward, and I want you to know that these are my opinions, but at the same time, they're reinforced by many of my colleagues, that I'm not just pulling this out of my hat. I really truly believe that one of our ways of minimizing the potential effect of this change in the law is to continue to do very dedicated work in palliative care and to provide that for everybody that's in need of it. I personally am disappointed that we are being rushed into this decision to prematurely help people die. I don't think it's been thought out, despite the fact that there have been, as mentioned by the previous speaker, that there's been lots of precedents set in other countries and different states. I think that Canada has many unique properties, and it's foolhardy to be trying to come up with a law that will suit the entire country and the individuals that are to be involved in this. So we know that death is a naturally occurring reality for all human beings and is one of the most difficult problems faced by physicians and healthcare personnel. For centuries, we've cared for the dying, but with modern medicine and life-saving interventions, we have drifted away from those frank discussions about death and dying. We're trying to bring it back, but we're still in the process of trying to educate people that it's not going to make it happen if you start to talk about it. It's a reality. You've got to prepare yourself. Palliative care as a focused treatment of seriously ill individuals really only began in the 1960s. Certainly people have had bits and pieces of palliative care, but it became a really cohesive understanding of the approach to people with a dying situation. So we have come a long way in the last 50 years, and we don't want to lose that momentum. We don't want to regress. If you look at a definition of palliative care, certainly the intention is neither to hasten nor postpone a natural death. There we go. Okay. So it's to be natural as much as possible. Palliative care offers support system to help the patient live as well and as actively as possible until the death. So the focus is on the living. Offers support system to help families cope during the patient's illness and their own bereavement. So there's the preparation, the expectation that something really significant is going to happen, and if you block yourself off and don't have anybody to support you to get ready for that, it can be very challenging for a loved one. The objective is to enhance the quality of the remaining life and positively influence the course of the illness. And there are many examples of that people who were very close to dying, or it seemed that they were close to dying, with proper care, live longer and have a better departure from the world. So palliative care requires that we be open and honest about the illness and death. It's difficult. There are different cultures, there are different family values that sometimes we have to tread rather lightly, but the intention is never to cover up or to not be honest about what really is going on. We're in the process with palliative care, we're preparing the individual and the family and the loved ones for the eventual event. And this happens with major gatherings together where we really have to be very intuitive and careful with the words through just small daily mentions of things. But it's not that we every day go in and remind people that, okay, remember you're here because, or that you're going through this experience because you're going to die. You pick the time and you do it sensitively. Still, even with all this openness and honesty, it remains an emotional time, even with preparation. Grief is a very individual thing, and the palliative care simply tries to facilitate the support before, during, and after the loss. We have in Canada the Canadian Hospice Palliative Care Association, and I bring this up because, of course, when you have a big organization, a national organization, you have policies and very clear written guidelines of what the association is supposed to be doing and what it supports. And it's written in black and white in their mandate that palliative care does not include physician-assisted death. So it's right there in black and white, and if the law changes, how will that be modified? I hope it's never changed. Also, that palliative care does not hasten nor prolong death. We're simply providing an environment where the most natural process can take place. And that palliative care strives to end suffering, not life. So on June 6th, if the law in Canada changes, as presented by the previous speaker, certainly the concept is it's no longer illegal for a physician to assist a person to die. But as you heard from the previous speaker, there's lots of difficulty with this, that it's a very scary thing to think about. The exact criteria and details are still being discussed, but already 3 individuals have applied and been granted a court exemption and have had assisted death in Canada. That's just in general. I didn't have time to look up what's actually been happening in Quebec because they have a different wording, and for a person in Quebec, I think the criteria is you have to be there for have to have lived in Quebec for at least 3 months before you can apply, but you do not have to wait the court decision. It's between the physician and the patient. So if you think for a moment, why would a person choose to end their life? And again, we've heard from the previous speaker lots of examples of people requesting it and actually being granted. One of the top of the list for me is unmanaged symptoms. When someone is suffering, whether it's physical, emotional, or otherwise, if the symptom isn't managed, then in desperation they want an exit. They want a way out of this horrible thing that's going on with them. Often people that I've had discussions over the years with people about, could I help them in some way? Could I assure them that they're going to go when it's appropriate for them? And often when we have a discussion, what really is the problem is they're not afraid to die or to be dead, but they're afraid of how it will happen. What will they go through? What will they experience? And I'm never able to tell them all the details, and because every death is different, but I can assure them that with palliative care, they will not be alone. They may be alone for that second that happens, because that does happen, but for the most of the period, they will be supported and treated as a very important living individual. Some people consider, they feel guilty being alive, demanding or requiring a lot from their families, hours and hours of bedside care or trips to the oncologist or whatever. They feel guilty that they're imposing that on their family and that they perceive themselves as a burden. So they can construe that as a reason why they should choose to die sooner than later. Realistically, people have financial concerns. We've had some tremendous situations over the years of people being in a really bad financial situation, and they just figure, okay, well, then maybe I'll just let this, hurry things up so that I won't have to be worried about that anymore. And we've had pressure from families. They can make the individual feel that, okay, like this is really like, I gotta get on with my life. I've gotta go to work again. I've had 6 weeks of bereavement care. Now what am I gonna do? So you can imagine that a very sensitive individual seeing this happen with their family or a family member would think, okay, maybe I should make a decision and ask for assisted death. And of course, as mentioned previously, loneliness, depression, and despair are huge incentives for someone to think, I don't need to be here any longer, it's not worth it. And the other one we talk about or mention is an intolerance for a medical problem. And there were examples, again, mentioned to you before. I've had many people, as a physician, dealing with not necessarily with life-threatening issues, but people saying to me, like, if I ever had to have my leg cut off, I'd rather be dead. Or if I go blind, that's it, I don't want to be here. And when you're fully, all functioning, and you think of that, you think, yeah, that would be awful. Like, I couldn't imagine that. And you think it's unacceptable. So if you have an advance directive and it says, okay, if I ever become blind, then I don't really want to be, I want to be given a physician-assisted suicide or death. But the reality is that humans can be very adaptable, given the right support and given the right understanding. So, there are many instances of people that have tragically lost sight or a sense or a limb, or even paralysis. I mean, there are many quadriplegics, and you wonder how could it happen? But they somehow find satisfaction, purpose, and pleasure, and continue to embrace life. And many of them are highly motivating individuals. Especially, I've known several quadriplegics. So basically, their mind, their ability to speak or to maybe type sometimes with their mouth, gives them a purpose. So they can, through their struggle, through their courage, can help somebody else. So again, it's the adaptability of the human spirit. So it doesn't have to be an exit when that happens. I wanted to mention to you a couple of examples of situations that really have happened. These are real individuals. So the first one's a gentleman who was in his 50s, and he has a degenerative neurological illness, much like ALS. So what happens with him and his body is that there's a gradual decline in all motor function. So first you can't sit up very well, can't walk, so things progress, just like with ALS. And he was hospitalized for pneumonia, which you can imagine is very difficult for someone who can't cough very well or can't take a deep breath, and was given IV antibiotics, but he became more congested, more frail, and then he began to have more difficulty breathing and swallowing and speaking. So it seemed appropriate that his disease was now taking on a new trajectory, that he was declining faster. And so his decision was that he wanted to come to hospice, which of course made it perfect sense, that he was coming to hospice for end-of-life care. But this reinforces that with palliative care and hospice care, we weren't trying to help him leave. We simply gave him the basis of care. He got supportive care, he was kept clean, he was kept comfortable, he was free from worry, and his symptoms were controlled. And what do you know happened? That we didn't intervene with major medical intervention, he didn't have IV, and he didn't have very many medications, but just because he was in an environment that respected his life, he gradually increased his ability to nourish himself and to get sitting up, and eventually this man went home to a loving household, and it's 3.5 years later, and he's still alive. Another example of a woman that was in my practice for 25 years, and she was in her 80s by that time and had a passage of rheumatoid arthritis, but she was a go-getter. She never let that slow her down. But then she developed an infection in her chest and was treated with multiple medications, ended up at the hospital. Things looked pretty grim. They did do a CAT scan and showed the unresolving pneumonia and that there was a mass in her lung, and it was assumed it was a cancer. But because of her frailty and because of her own request, she didn't have a biopsy. So there's this picture that looks pretty bleak for her. So she requested to come to hospice and again receive palliative care, and without really any expectation on our part, with just gradual improvement, she was discharged after about 4 months. And it's 2 years later now, and she's had a recent CT scan and there's no mass. So was she cured, or was she probably never had cancer in the first place, but her family thought it. We as physicians thought she had a terminal illness. The third example is a woman that I've known who is now in her late 50s, and she had cancer 15 years ago. And it was a cancer that is one of almost always fatal, but in her case, with chemotherapy and surgery, she survived. Then this November, she developed a bowel obstruction, which means that her bowel was completely blocked, and the surgeon, she had to go into emergency room, the surgeon offered her, well, I could do a colostomy, which is the opening on the side which will allow the bowel to bypass the obstruction. And she said no to that, but she would accept an operation to try and just bypass the obstruction so that she would have some comfort. And she went ahead with that, and at the same time the surgeon did a biopsy because he's in there and he saw it was there, and of course he had a previous okay from her. So he saw in her belly a mass of different tumors, and the biopsy came back that it was the same cancer that she'd had 15 years ago. So this was pretty devastating news for her because she'd worked so hard to be well. So she, again thought, well, I just don't have the courage to fight this anymore, and I'm not going for chemotherapy, I'm not going for any radiation. And truthfully, had she gone to the oncologist, they probably would have said, given your clinical status, the extent of the disease, the treatment might be more harm than good. So she came to hospice. She did not have a bowel movement for 4 weeks, which is, it's not usually compatible with life, because usually the bowel becomes distended and leaky, and you end up with a very serious infection and eventual death. But she didn't have that. She had no bowel movement. Her nausea and vomiting were managed quite well, and again, she gradually improved and started to gain weight, and she eventually went home, which was now 4 months ago. And you can tell she's not free of disease. You can tell just by when she stands or when you touch her abdomen. There's still bad things in there, but her pain is controlled. She's up and about. She's with her family, and she's telling me she's going to plant a little garden this summer. So all 3 of these people would have met the criteria for physician-assisted death or euthanasia had it been available at the time. Yet all 3 have had a meaningful extension of their life. So they would have died too early if they'd been given the opportunity, and they would have deprived themselves, their families, and their loved ones of their companionship. And this is what life's all about, is being with people and sharing things. So the big concern for me is, how can we be sure a person is really appropriate for assistance in dying? I've been working all these years and seeing people in critical situations, and I'm not sure I would have made the right decision in these cases. If you reflect a bit about palliative care in our area and the hospice, we've had more than 900 deaths since September 2009 when we opened. And over the 33 years I've practiced, I've seen plenty of deaths in homes and hospital and hospice deaths. So I've seen death, but even I am not sure when someone's going to die or when they're imminently going to die. Usually we're pretty good within a day, but until it gets to that point, we're not really sure. So the whole process of palliative care it's not perfect, but we're learning all the time. Research is ongoing. We're trying different managements, and it's a living, progressing specialty. But having said all that, the majority of people that I've been privileged to work with at the end of their life have died in a calm, dignified, and comfortable state that leaves their family and caregivers with a good memory of the death. So, sorry, I forgot the slide. That's the essence, is what I'm trying to say, is that we're trying all the time, we're trying to improve things, we're trying to make it as easy for people that have to die at the appropriate time to be as natural as possible. But we're not at all interested in trying to speed up that process or to decide today is the day that you will leave. Palliative care is an active treatment. So some people have the concept, well, you just put them in the room and keep them tidy and that sort of thing, and just let it happen naturally. Well, it's active. We have to, on a daily basis, adjust medications, try different things. And it's a team effort. The bedside staff, the nurses, the PSWs, RPNs, they're the ones that are seeing more of what's happening because they spend more there. And a physician walks in and we get the report, but we have to do it as a team, because sometimes when you see something happen or you experience something, you have to interpret it with what other knowledge you have. So sometimes a person being angry, for instance, well, why would they be ticked off today? Was it because the breakfast was cold, or is it more likely it's because there's a symptom that they're experiencing that you haven't asked them about, so they haven't brought it forward to you, so that the anger isn't the real thing, the anger is the sign of something else. So again, palliative care, we're not really expecting that we're going to cure people, but we're relieving the suffering. And we have to remember that the suffering is more than one dimension. It's not just physical things, it's emotional and it's spiritual. So we have to address those things to help someone have the best experiences possible. And I believe we can control most of the symptoms of end of life. And those that we're still struggling with, again, there's more research and approaches being developed. And above all, palliative care respects the individual's dignity and their life. So the definition of palliative care, again, intention is to neither hasten or postpone a natural death, that we're doing this support for the family and the individual. There are numerous reports in the literature of palliative care, patients contemplating suicide. And we're happy to report that with good palliative care, that showing that with quality care, there can be improvement in mood and renewed interest in living. So we don't expect that they're going to be cured, but we try and give them that renewed interest in being alive. Similarly, patients receiving palliative care can live longer and have opportunity to deal with important end-of-life issues. So just reflecting on those 3 people that I mentioned, they've been given an opportunity to continue to live. We didn't try and end it. We tried to get them through the difficult phase, and what do you know? They've gone on to be around for quite a bit more. Feeling depressed enough to want to end their life is uncommon in well cared for terminally ill patients. And I can verify that from my experience, that until this discussion started in Canada, it wasn't infrequent for someone to ask me about it, but when we talk about it, do they really want it? No, they just wanted to know if that's what I was going to do, or that what would I suggest if that was their question. So I've had many conversations about it, but very few people have actually asked me that they wanted it and how would they go about it. So one of my questions is that will legalizing physician-assisted death in Canada have a negative impact on availability of quality palliative care? This is something that I'm personally very concerned about, because in our medical system, all of our health care is government funded. I mean, there are a few private things going on the side, but the bulk of it is government funded. And it's a limited amount. It's a budget thing, that's it. You make it do for the year. And if physician-assisted death is readily available, will the government still fund palliative care to the extent that they do? Because as mentioned in the previous speaker, sometimes you know, a quick exit would save a lot of expense. And already with palliative care and hospice care, the government is not generous with the funding. Despite many surveys and pleas to them that we, certainly hospice and home visits, are saving a great deal of money that the hospitals can use because we're keeping those people out of the hospital. They still don't give us the total extent of our funding. So we have every year a stressful amount of fundraising that we have to do to be able to pay our staff, to be able to provide for some of the things that the patients themselves require. So my question to you is, why would we need palliative care? Why do we need it? Well, it's obvious, the people that have experienced it, because it works. Palliative care is a very meaningful, important part of health care. And what we need is, we need expert palliative care for everybody in Canada. I mean, it's not good enough to have it in the bigger centers. We need it everywhere. And the only way we're going to get that is by educating people of what palliative care can do and why we need to support it. So that was basically what I wanted to say. And I think the previous speaker, sort of a lot of it kind of overlapped. But if there's any questions about palliative care, any comments you want to make, I'd be happy to try and answer them.
Dr. Randlett, is there, in the hospitals, is palliative care, there used to be a unit. Once hospice opened, we lost the unit. I believe there's beds that are available on different floors, but is there a program where whenever a family feels that their loved one should be on palliative care, is there a program set up that you can ask to have them put into that program as far as medication and?
Well, the quick answer is no. And it wasn't because hospice opened that we lost the beds at the hospital. That had started to happen when the amalgamation of the hospital started. And I mean, I've fought to try and keep it, and I still go to the palliative care committee meeting and trying to do what I can. So it wasn't because of the hospice. The hospice, we lost those beds. The hospital does not have the same perspective as palliative care as we do, so they keep putting it aside. We get a promise in 6 months, okay, we're going to get 2 beds and the family room, and we'll expand from there. Well, they keep chiseling away at it, and so there is no dedicated program. We do have a family room, which is supposedly only for the family members of someone who's critically ill, and we do have now, again, a set of standing orders. So if a physician there deems the person palliative, then these orders can be used. And the reason we have them is because it makes it easier for a physician who's not familiar or as familiar to remind them of all the things they should be concerned about. So we have the standing orders, we have the family room, and we have anyone that's in the hospital that the physician that's caring for them thinks that myself or Dr. Lee could be a benefit, they can ask us to come in and see them. And so I follow a few patients at a time at the hospital for palliative care. And because I'm sad about the whole situation at the hospital, I quite frequently mention hospice as an option. Or, can we get you home and I'll do it, I'll help you at home. It's just the reality of the way the hospital's developed. But we're still optimistic, and I think there's a couple of internists at the hospital now who have experience in palliative care, and they're receptive to the fact we've got to have a more defined area and a program there. Because it's not just the medical care, it's the spiritual care and the social work, all those things that the hospital has, but they have them on limited hours, so the bulk of them, are not working at palliative care. Sorry, another part?
I find too, in a lot of the hospitals, the nursing staff and some of the doctors aren't comfortable, like with end-of-life care, and they're very hesitant to give anything for if the patient is agitated or and the family are sitting there. They know the patient. They know that they're squirming around or they're sore, but yet the nurse walks in and says, oh, they're quiet right now. I think they're fine. We won't give them anything.
Yeah, no, it's true. People are not everybody has the experience to understand what's happening with an individual that's at end of life. We're trying to expose physicians and medical staff to more of that with specific training. Medical schools are more, they're training physicians better to do this. And again, it's openness, talking about death and dying. It's not something that you can ignore. It's going to happen. So it requires education. It requires people speaking up. Like if you have an experience that's not appropriate, the hospital has to hear it. They need to know, because they need to then decide, okay, we've got to meet the expectations of the community. We have to provide more focused care. So it's all part of education, but don't give up. Yes?
Is there a clear financial argument that we could present to government about increasing the number of beds in hospice care, as far as like a direct savings for every patient that you take out of a hospital?
Oh, we've done that. I mean, that's what, as a group, the hospices in Ontario, there are about 26 of them now, have presented that repeatedly to the government. How much does it cost to have a person in a bed in hospice per day, as opposed to what happens in the hospital? So we keep, presenting that to them, and the fees go up every year, but they go up proportionally higher in hospital. The second part of the equation is that if we're having good community palliative care, we minimize the trips to the emergency room. So for instance, if I have a patient at home, the nurse has to call me first, or should call me first, before they authorize the transfer to the hospital, to the emergency room, because many times it's not appropriate. It's a symptom or one we could have predicted, and it's part of what's going to go on, and the family just needs to know that, or we have to bring in some medication in the home. So we've been doing it, but if an individual, private individual, or a group wants to do it, it only adds fuel to the fire. Basically, we estimate that a day in hospice is anywhere between $300 and $500, and 1 day in hospital is about $1,300. So, for that one day in hospital, we could have 3 people in the hospice. Anybody else? Yeah.
I have a question in regard to medication. I know in hospice and in hospitals, we are, any kind of a narcotic, we have to be very, very careful as far as keeping a very specific count, and as nurses, we're accountable for that if there is some kind of a problem. If physician-assisted suicide, or unfortunately, when it becomes legal, a patient receives a prescription. They go to the pharmacy, they get that filled. Maybe they're one of these people that just wants to have that medication there as kind of a safety for them in the event that it gets too bad. But let's say they don't use it and their natural death proceeds. This medication that they have there, we know can cause death, versus like 5 milligrams of morphine or something, depending on the situation. But there doesn't, or will there, do you think, be any accountability for what happens to that medication if it was not used? And how can we prevent that, even a child, or say a caregiver? There's a tremendous amount of stress with a caregiver a lot of times, that it not falling into the wrong hands.
I don't think that's been thought through. I don't know what happens in other jurisdictions, but there's been no mention of exactly how that's supposed to happen. Currently, one of the medications we commonly use was fentanyl, and it's got such a bad rap in the communities for people overdosing on it that now they have a system where you can't get a new patch unless you return the used one. So, there's more heightened awareness of things that are happening in the community. For this particular thing, we have this thing called a symptom management kit, which we send into people's homes when we feel that it's getting close, and it's supposed to stay sealed, but it's just a cardboard box. You know, you can peel it. So it doesn't have really that much medication in it, but this, you're right, it's a lethal dose for a big person, a little person. It's probably not based on any kind of weight or anything. The only way I can see that it would work is if what you get from the pharmacy it's locked in a coded thing. And if the time comes that it's going to be used, you have to get the code from, I don't know who. And if you don't use it, it has to be returned. Like, I don't know how they're going to do it. I mean, because, you know, oh, I don't know what I did with it. You know, I didn't use it, but I don't know what I did with it. It's going to be a nightmare. You know? I think if, I don't really want to surmise, because I don't want to help anybody with the ideas, but maybe it will, you know, if this goes through, that it can't be done just in a home. You've got to go somewhere to have it done. And therefore, the people that are doing it would be responsible for the medication. I don't know. It's a sad thing to think.
We really do need more beds in the hospice. We need more hospices. Let's say, do you have any idea if there's any plans in the future for that?
Yes. Yep. There was an announcement from the government that they were going to fund the establishment. They're not going to build them, but once they're built, they will allow up to 10 more hospices in the lower southern part of Ontario. And Hawkesbury is very active in trying to get one going, and I think there's one Kingston and Brockville. They're all trying to get one going, but I mean, it is a process. I think a lot can be speeded up these days because there have been a number developed and they can use the plans. They don't have to start from scratch. So there's good things coming, but it all takes time. Yeah. And the manpower, that's the other thing, is Cornwall's never had enough physicians since I've been here, and I did, there was Dr. Irwin and Dr. Delorier when I first came. They were doing some palliative care, and then kind of myself, and recently Dr. Lee's come on board, and she's been a great, great help, but she's a young physician with a young family, so she hasn't got the hours available to her. So we've got to get more physicians, and we have a great group of nurses that are being trained and will do what they can, but we need some more directions. And again, when you have one hospice, like, we can't totally manage another one, but we can really give them support and get them off the ground quickly, because we can give them a lot of the experience or tell them of the experiences we've had. If we could do it again, what we would do. Yeah. But in Cornwall, people have asked, well, it's only a 10-bed hospice, and why not just build it bigger? The problem I feel with that is that then it becomes more of an institution, and the whole focus is to try and keep it small, more intimate, and more home-like. And so we would rather have ones dotted around. We have a great number of people that come from Winchester and Alexandria. They need something closer to home, so their people are not driving every day long distance. So, anything else? I think you guys have had a super day, lots to think about, and let's just take a big deep breath and hope that June 6th comes and it isn't as fait accompli as it seems to be right now. So, okay.
Thank you.